Go
Hi.
ahead.
Oh, thank you, Megan. Hi, welcome everyone to our Significance of Chronic Wound Management webinar. Thank you for taking the time out of your day, especially during lunchtime, to learn about this subject. I know Dr. Red's very excited to talk to you about it. Like Megan said, my name is Lauren Gravy. I am an RN of over 11 years, and I'm the Director of Clinical Services for ProHealth One and will be one of the panelists today during the webinar. And I will be monitoring the Q&A box. So, a quick note about that before we start. Please use the question and answer box to ask any questions throughout the presentation. We'll address those questions during and after the presentation. Also, we will have polling questions throughout the webinar today in order for you to get credit for any continuing education hours. Please make sure to respond to all those polling questions. And without further ado, I'll introduce Dr. Brooke Red. He's one of our wound care physicians at ProHealth One, and I will pass it along to him.
Thanks, Lauren. Yeah, I'm Dr. Brooke Red. I've been doing wound care really my whole career as general surgery for 26 years or so, and been doing wound care only with ProHealth One since the beginning of 2020, right before COVID hit. So today we're going to talk about significance and management of chronic wounds. Next. So this says for information only, for your education, and I have no disclosures. Next. Our objectives today to analyze and learn more about intrinsic and extrinsic factors that contribute to chronic wounds and the use of mnemonic dimers, DIMERS, as a framework to guide our uh, diagnosis and treatment of chronic wounds, highlight the practices to treat wounds, documentation of those as well. Next. So, some quick facts about wounds. In 2014, there were over 8 million Medicare beneficiaries had at least one wound. And these are very expensive, averaging about 32 billion a year for wound care. When untrained professionals are dealing with wounds, it leads to worse outcomes, seen by more referrals out of facilities, more trips to the ER, and more readmissions. Next. Pressure injuries are a big part of that. Over 2.5 million pressure injuries are recorded every year, leading to 60,000 plus deaths, and these are also very expensive for facilities and hospital stays and/or judgments that come along with that sometimes. Next. All right, first polling question is, what is your primary role in healthcare?
I'll just give just a couple seconds left for everyone else to answer. Okay.
Okay. Mostly other. Okay. Thanks, Megan. Next. All right. That's the difference between acute and chronic wounds. Acute wounds go through the healing process quickly and orderly from hemostasis, inflammation, proliferation, and remodeling. Chronic wounds fail to progress and are open for more than 28 days. Next. Underlying conditions, of course, contribute to wounds, especially chronic wounds, be it arterial, venous disease. Diabetics have more trouble, as well as patients with more pressure tend to have more chronic wounds as well. Next. So why are they difficult to manage, and why do wounds become chronic? These are questions we need to ask ourselves so we can treat them better. Next. We're going to look at intrinsic factors and extrinsic factors that contribute to chronic wounds. Next. Start with intrinsic. Use this mnemonic to help us think through the problem and eliminate some of these reasons as we can. So use did not heal. Start with D for drugs. Next. So steroids are going to inhibit all phases of wound healing as increased risk of infection. Anticoagulation medications and anti-inflammatory agents also inhibit wound healing by their action on platelets. So what can we do about that? Talk to the PCP about stopping or maybe reducing steroids or some of these other medications, and document why they're on some of these medications that can inhibit wound healing and why they cannot be stopped. Next. I is for infection. So infection is going to delay wound healing primarily by causing lysis of collagen, which is necessary for basement memory to heal wounds. And all these signs of infection we should be aware of and look for if the wound is not healing well. Interventions we can do labs and x-rays to help diagnose infection. Antibiotics may or may not be necessary, either topical or parenteral. And looking for signs of osteomyelitis to help with infections. Next. D is for disease, particularly diabetes. Our diabetics have much more or many more issues with wounds than other patients. Elevated sugar inhibits all the cells that are trying to get to and help a wound heal. Elevated sugar can also, and changes can cause decreased cardiac output. As you know, diabetes affects every system that we have. Can talk to the patient about their diet, their medications, their motivation to help control their blood glucose. The dietitian needs to be involved to help with diet and motivating the patient to cooperate. And we need to document if they are cooperating, particularly if they're not cooperating with diet and other interventions to help control their diabetes. Next. There are other diseases that contribute to development and prolongation of wound healing. Cardiovascular disease, decreased blood flow of oxygen and nutrients to the wound. Kidney disease, malnutrition, even in obese patients, or particularly low on protein. And their ability to understand and cooperate, whether they with the treatments from dementia, etc., take an extra effort to help them understand what's going on and or motivate them to participate. Cancer, either cancer itself or treatment causing immunosuppression, and then anyone who's immobile is going to be at increased risk for wounds. And aging, particularly that last note there, 800 out of 100,000 individuals over 75 have a chronic wound. Next. Nutrition. So malnutrition obviously plays a big role in wound healing, particularly vitamins A and C, as well as zinc. Sometimes we'll just add these to the diet or talk to the dietitian about adding these to our patients with wounds to help them heal. Labs may help to diagnose or with malnutrition. Again, talking to the patient and the dietitian to get them to cooperate with the dietary recommendations that we have to help things heal, and document their compliance or non-compliance with dietary recommendations that we make, and that's something that we can follow up on if they're trying or not to do that. It's pretty easy to ask how they're doing with protein intake, and a dietitian to try to find things that they like and will eat. Next. Oop. We skip a question. Nope. Okay, sorry. All right. O, did not heal. O is for oxygen. Obviously, with lack of oxygen, wounds are not going to heal well. Smoking is a big part of that. Smoking itself, as well as the vascular disease that comes along with it. I find it helpful sometimes to discuss why smoking inhibits wound healing with vasoconstriction, decrease oxygen, etc. to the wound. Some people respond, some don't. But we need to have that conversation and document that we did, at least talk to them about it, maybe get their PCP involved with smoking cessation with or without medications, and consider, those with peripheral vascular disease, which I'm sure they all do have, be getting ABIs and or consider referral for their peripheral vascular disease. Next. All right. T is for tissue necrosis. I say dead skin is mechanically in the way for healing, causes more inflammation, which causes the wound to stall out, and increased risk for infection as bacteria love to be in and grow in dead tissue. The treatment is debridement. Next. There it is. Okay. Polling question number 2. How familiar are you with dimers as a framework for chronic wound management?
I'll give just a couple more seconds for anyone else to answer.
Okay. Well, glad you're here today because we need to discuss this. Okay, next. All right, back to you. Did not heal. H is for hypothermia. Low temperature delays or stops wound healing, particularly related to dressing changes. We need to keep our patients warm and their skin warm to help the healing process. After a dressing change, it can take 4 hours for the wound to get warm enough to begin the healing process again. So if you were doing 3 dressing changes a day, that'd be about 12 hours a day that no healing is taking place. So again, keeping patients warm and minimizing dressing changes as we're able to can help with that. Next. E is for excessive tension or epibole, uh, which is incomplete closure where the skin, instead of growing together, curls down and creates skin on the edge of the wound instead of across the wound. And what we need to do is remove all that epibole skin, get restarted so the skin can grow across the wound. And sometimes this can be done at the bedside with good anesthesia or may need to something more extensive maybe. Next. A has another wound with multiple wounds competing for all the resources. We're going to delay healing at all sites. Again, dietary can play a really significant role here too in helping patients get more nutrition, more calories, more protein. Next. L, loss of sensation in our paraplegic, quadriplegics, or those with neuropathy. Assessing their numb areas and what we can do about is really important. There's just a quick look here at this person in this wheelchair. What do you notice that's good or bad? Let's say first, there's no padding on the arms. It looks like there's a seat cushion, but it's a little hard to tell. There's no seat belt, which is a good thing. And then their feet. Are their shoes fitting well? Are they not rubbing anywhere? I don't see any padding on that strap that's over the feet, holding them in, which should be addressed, and if there are any padding on the heels. Next. On to extrinsic factors. So like this wheelchair, the wheelchair cushions, we need to look at those. Are they worn out? I mean, I'm sure we've all seen multiple wheelchair cushions that are too thin to really be helpful. Or are they, if they have air, are they full of air? Again, their bed, if they're mattresses that help with low air loss or alternating pressure. And if they're not tolerating those things that we recommend to reduce pressure, we need to document why that's not happening. And then transfers. I really, I really like it when I'm in the room when they're transferring a patient. And yeah, it takes longer to do my thing, but I really like to watch how they apply Hoyer or sit to stand. And when I mean, they're much better at it than me, but you can tell when it's incorrect and the straps or even the mesh is causing a problem and take that time to educate the CNAs and nurses to be more careful when we notice that particularly the straps are causing a problem. Other intrinsic factor, moisture. Increased moisture allows infection, either bacteria and fungus to grow, making the wound edges more friable, more susceptible to pressure, shear, or friction. And then being aware of friction and shear injuries as patients sliding in a chair or in bed. And remember that friction and shear are actually pressure injuries. Next, on to chronic wound management. Next. All right, preparing the wound bed we need to do that so that we can promote healing, reducing bacteria in the wound, dead tissue, as we see in this picture. Keep the wound environment warm and moist, but not too moist. And then being aware of other underlying conditions that are going to make it more difficult to heal. Next. Right, to dimers, it's good mnemonic to I think remind ourselves as we're dealing with wounds or any of these things going on because they'll contribute to delayed wound healing. Next, D is for devitalized tissue and debridement. We need to get rid of the dead tissue so the wound can heal, reduces the bioburden, reduces the amount of bacteria that accumulate in wounds. It's necessary for these chronic wounds to kind of jumpstart them, if you will, to begin the healing process again, to move beyond that inflammation phase. It allows us to inspect the whole wound, see how deep it really is, and for topical medications to penetrate into the wound. Next. There's two types of debridement, the selective and non-selective. Selective removes only the non-viable tissue. Non-selective removes viable and non-viable tissue. Um, Sometimes that works to use non-selective, but we prefer to use selective. Next. Okay. Kind of the bottom line here, sharp debridement leads to better wound healing. Multiple studies have shown this. There is a strong correlation between better healing rates and sharp debridement. Next. Well, let me add, sorry, back to that even in diabetic or venous stasis ulcers, debridement does help. Next. Next. An eye infection, let's see, infection inhibits wound healing. Remember the most common way infection is transmitted in the healthcare setting is with our hands. Some of you might have participated in these studies during COVID. That's when I saw a lot of them going on where facilities that I was in, but 50% of opportunities to clean our hands were missed by staff. You know that 1 out of every 25 patients has a healthcare associated infection in the United States that leads to about 90,000 deaths a year. Next. Go on the bioburden cycle, contamination, colonization, critical colonization, and then infection. Next. Contamination. Every open wound is contaminated. We can't get rid of all the bacteria on our skin, which is the most common place that these infections come from. It can come from anywhere in the environment or from inside the body, particularly GI anaerobes. At this contamination stage, there's no signs or symptoms of infection. Next. Colonization is when these bacteria on the wound begin to multiply. It doesn't impair wound healing, At this stage, there are no signs of infection, and systemic antibiotics are not appropriate. May consider topical antibiotics or antimicrobial dressings. Next. Critical colonization. There's some controversy and interest around this stage. That's where the microbes begin to form a biofilm, and that inhibits wound healing. Signs and symptoms of infection are not necessarily present, although this picture, it looks like there's some erythema and probably some exudate. So we're looking for with critical colonization, it's delaying healing. So non-healing, there's increased exudate, more erythema. And we need to debride any devitalized tissue or biofilm that's present. And sometimes they're even malodorous. Next. This pretty severe case of critical colonization in this picture, but it's more likely related to the bacteria than the patients. Is more the issue here. And classic examples you hear this greenish drainage, sometimes blue, red, or even brown. Next. Right. So, again, infection, or which the other I we can use there is invasive. So when the microbials are more invasive, begin to overwhelm the host and causing a host response, not just locally. And the gold standard is greater than 10 to the fifth bacteria per gram of tissue. Some species like beta hemolytic strep can be invasive with a lower count. Next. So that microbials overwhelm the wound and the patient, often with systemic signs. Things we need to look for to be more aware of infections present. The wound's getting bigger. Their temperature is elevated, not just warmth around the wound itself. Bone may be palpable or exposed. There's new breakdown of tissue. Goes along with increased size, more erythema, more edema, more induration, increased exudate, and probably malodorous at this point. Next. So some blood work may be helpful in diagnosing and probably more in following wounds that are infected to see if our treatment is effective, CBC, CRP, and sed rate. Next. Right. So again, culture is the gold standard for diagnosis, skin or bone, which identifies the organism and will give us some sensitivities to help know how to treat it. Next. For all infection, but particularly noted with osteo, we do as much workup as we can in the facility. I would say, if you can see bone, it's probably infected, which can lead to serious life and or limb-threatening conditions. It can be difficult to diagnose. Lab and X-ray, we can do those from the facility, and then a bone biopsy with culture is probably going to be indicated. Sometimes we can do that in facility, but sometimes not. Next. Our third polling question. What is your biggest challenging in managing chronic wounds?
We have just a couple more seconds for everyone to respond.
Mostly patient compliance. Yeah. Okay, next. All right, continue with infections. These are obviously a big deal for our patients, our facilities, and ourselves as we're trying to manage wounds. May need a ID consult. Keep that in the back of your mind. If you're going to diagnose an infection, we might want to use some careers. Right. Just encourage you to look this up. Keep a copy in your bag or with you. But I do that just then I don't have to try to remember it. I can just look it up every time I want to document that there is an infection. But roughly, quickly includes fever, leukocytosis, acute mental status changes, functional decline, and then the wound itself, pus from the wound. And other characteristics, increased warmth, increased erythema, swelling, tenderness and pain, and drainage. Treatment, using aseptic or sterile technique for wound care, antimicrobial or antibacterial dressing changes, topical antibiotics, parenteral antibiotics, or even using the moleculite to help diagnose the infection. And treatment could include HBO when they get more severe. Next. Dimers, M is for moisture management. Don't want it too wet or too dry. Again, excess exudate leads to maceration, which can lead to more infectious problems around the edge of the wound and makes the peri-wound more friable, more easily torn, and the wound can expand. In bigger wounds, the exudate can cause a problem for the patient with loss of protein, fluids, and electrolytes. To protect the peri-wound, skin sealants or barrier creams, I think zinc oxide is what I usually use for big wounds. Highly absorptive dressings, alginate or foam. And if it's draining a lot, you may need to use the negative pressure wound therapy. If they can tolerate compression, it may be helpful to reduce the amount of drainage from a wound as well. Next. E, edge advancement and epibole, where the skin, instead of growing across the wound, curls down and stops at the wound base. And the treatment is opening the wound edges, removing the epibole part of the wound. Sharp debridement is preferred. Sometimes silver nitrate or mechanical debridement might help. And I would say maybe if part of the wound has epibole, but if the entire wound has epibole, it really should be excised. To help prevent this, packing the dead space, again, loosely packing. We'll come back to that in a minute as well. Protecting the wound edges as well can help prevent this. Next. R and dimers, repair and regeneration. If the wound is stalled out, we need to consider and use some other interventions. We can't or shouldn't keep doing the same thing. Consider negative pressure wound therapy, growth factors, skin substitutes, maybe grafts, and again, maybe HBO may be necessary. Next. And social factors, of course, we know these can be more difficult to address and get the patient to participate, but consider their whole situation, including their ability to understand what's going on, what we would like to do to help them heal, and honoring or being aware of their choices. We include the patient in the care plan, which seems intuitive, but sometimes it doesn't happen that way. We decide what to do as the health or wound care team and then tell the patient what we're doing. But particularly for those who are prone to non-compliance, it's great to include them in the process. Family, other caregivers can be helpful as well. Use active listening to make sure they understand what's going on and to assess their goals. And I would say try to get them to agree with our goals for wound healing. Next. Why is all this important? Next. So the main reason improves patient care. A knowledgeable care team, if everybody's on the same page, reduces the variability from day to day or dressing change to dressing change, improves their outcome, which is what we're really all after, and decrease referrals, which is significant for the patient and the facilities, decrease readmission rates, decrease costs, and helps prepare us and facilities for the next survey. And following these guidelines does improve the healing process. Next. All right, pain management. Next. Some non-pharmacological options with lower extremity edema. Elevating them can reduce edema, reduces pain sometimes. Offloading, which we should already be doing. Using devices to move patients or lifts instead of sliding them in the bed or in their chair. Even though it takes longer, we really need to do that to reduce the shear and friction injuries. Consider immobilizing areas that are painful and always use transfer devices. Next. Other non-pharmaceutical operations options. Non-stick dressings, avoid gauze, hydrogels, or silicone. I think are especially useful. Don't allow the dressing to dry out. Remember, a normal saline wet to dry is not a dressing. It is not a treatment. We still see it. It's pretty old school. Some of us older people did it all the time, and we go, oh, shouldn't be doing that anymore. And then reduce the frequency of dressing changes as we're able to help the patient be more comfortable. Next. All right, psychological interventions. It's just kind of prepared ahead of time for a lot of these. This makes it a little bit easier. Addressing their anxiety, their concerns, reassuring them. I think it's really helpful to explain the procedure and what they are to expect because it's probably going to hurt when we're at this point. And not to minimize that, pretend like it hasn't happened, but say, yeah, it's going to hurt. But here's all the things we did to minimize that and reduce that pain. And some of these distraction, other therapies can help too. Next. All right, things we can do, pre-medicate, call ahead when we're getting close to facility uh, for PO medications, or if we're anticipating debridement on some of these chronic wounds, maybe a lidocaine soaked gauze can be on the wound before we even get there. Positioning the patient so they're as comfortable as possible, which is challenging for those bilateral hip wounds, but still need to keep that in our mind. And again, reducing frequency of dressing changes, reducing pain and temperature issues as well. Don't overpack. That's going to cause more pain, more pressure, slow healing. Again, loosely pack these wounds and make sure the drains are thoroughly soaked before trying to remove them. Next. All right. Other things to reduce pain, using skin sealants and barriers to protect the peri wound. And silicone dressings are great. Maintain a moist wound. And timeout. So in the middle of a dressing change or debridement, when it is painful, sometimes we just have to stop and wait or apply some more lidocaine. But be sure to take your time to do that. And don't poke the wound just to see if it's sore. Next. All right, to documentation. One of our favorite things to do. All right, primary purpose, communication of documentation. That's why we do it, to communicate with everybody involved and take care of the patient, particularly their wound. Can help provide a comprehensive picture of what's going on with the patient and their overall status. And accurate and thorough documentation will help derive treatment and help with discharge planning. Next. All right. what should we document? Pretty much everything that we're doing or thinking, uh, particularly non-compliance and refusals. Every time. Yep, every time. Seems kind of redundant, but we really need to do that when they refuse or not being compliant and why. So, um, because that's important for other people trying to help them be more cooperative. But why they're refusing, is it pain, timing? Um, I showered yesterday, I'm not doing it again today. Whatever, all those reasons that they give us, we need to document that. And again, go back. Maybe every time you go back, document that you went back and tried to convince them to comply with or treatments and that they refused again. Um, and in notifying the PCP, if the wound nurse isn't on rounds, make sure they know about the non-compliance that particular day. Again, if sometimes family can be helpful in helping the patients be more compliant. Next. So what we should be asking ourselves is, why isn't this wound healing? Uh, and documenting what we find, particularly, and then the other issue is if it's unavoidable, uh, doing the documentation for that. Okay, next. All right. Just we know, should be aware that CMS considers pressure injuries as should be never events and they should be avoidable. But that's not always the case, and it's only unavoidable if we in our facilities are following all the steps involved, including evaluating their risk for pressure injuries, in what interventions were used, are they really done, how is that affecting the area in question. So the monitoring, ongoing monitoring is important as well. And if it's not going well, what we've done to change our approach to these wounds. Next. All right. This is a form we have from Pro Health One. I really like using this. I think it's got everything that the state is looking for. And I would say if it's easy for the state to find the information on unavoidable wounds, they're more likely to agree with us that it is unavoidable than if they have to go searching and can't find information that I think all of it's right here on this form. And I use this initially, of course, but also on repeat visits if it's, I mean, it's still unavoidable. And that can be helpful, I think, with the state, but also for the facility with all to re-document these unavoidable situations. So, and after you've already done it, some of this information you don't have to do every time because it's going to be the same. Like their past medical history isn't going to change. Their labs may, maybe not. Their current weight would be about a new number there, but that's pretty easy to find. And then your impression of what the root cause of this chronic wound is. What dietary interventions are being done, what pressure devices are being used, and are they being used? Are they being turned? Is the patient compliant or not? And then are the uh, devices functioning properly, particularly air mattresses? I mean, I'm sure you all walk in a room and see the pressure on max. Maybe the patient just got changed or moved, and then whoever did that forgot to lower the pressure again. So always check and okay to document that as well, the pressure in the mattress. And then you're documenting refusals, and here's they're placing that bottom box on the left to again indicate that refusals uh, did happen and it was documented. And then chart and care plan, again, this you don't have to do this every time because it's not always going to change, but they're assessments, Braden scores at the beginning when the wound occurred, and ongoing Braden score. Were the appropriate people not notified and when, and was like documentation of treatment initiated. When was that documented? Are you assessing their pain? What education did you do um, for staff and the patient? And were the appropriate people notified and when? So again, a lot of this information won't change week to week. Um, but again, I think this is really useful for documenting unavoidable wounds. Thanks. Lauren? Let me add, on the next slide, we'll get to, if you don't have those unavoidable forms, you can get them through this contact with ProHealth One. Thanks.
So we have some upcoming webinars coming up in the next couple of months. Next month, we'll be doing burn management with Dr. Yaffe. And then Wednesday, October 1st, we'll be covering palliative care. And then in November, for Pressure Injury Prevention Month, we will be doing a webinar on pressure injury prevention. So please, if you'd like to attend those, that would be wonderful. We will send out more information on the following upcoming webinars as they get closer. And then for contact information, like Dr. Red said, there is an email here, info@prohealth1.com. You can email if you would like that form of the new wound investigation. We do have an outpatient clinic as well as providers going into our facility. So if you have a patient that's discharging and would like to be followed by us, then there's our information as well. And so I'm going to leave this slide up. And are there any questions for Dr. Red? So we have one question, Dr. Red. How often should you reassess chronic wounds? Or how often should chronic wounds be reassessed?
Yeah, like at least weekly. So the provider is going to do that weekly. And um, again, it's a good exercise to go through that dimers. It's something just to think through. What are those? What things are going on um, that can contribute to chronic wounds and make sure we're not missing something or something hasn't changed with the patient. So I think it's helpful to go through that weekly, even though the answers may not change, but it's good to think about it. And also, if the wound's not improving after a couple of weeks, just in the top of your mind, if it's not getting better, we need to do something else to try to make it get better.
Awesome. Next question. How often do you utilize that investigation form?
Anytime a wound is thought to be unavoidable, um, that's the easy answer. But there are some gray areas, and sometimes I'll use that um, um, mostly at wound nurses' request when things are starting to look bad, and oh, by the way, here's four things that happened that we didn't know about last week or weren't aware of in their history that can contribute to a chronic wound. Um, and so sometimes I'll fill it out when I think it may become a problem, just a little CYA kind of thing there. But once you've got it, once you've got that documented and started, um, it can offer some protection, I think.
Awesome. Another question. Who do you recommend as core members of the ideal IDT team involved for chronic wound management?
So the wound nurse, the every nurse that takes care of the patient, uh, every CNA that's involved, and the providers that come in uh, as well. So that's a minimum. Uh, and then as if wounds get worse, well, let me add the dietitian to that in-house. Um, and then if things get worse, then referrals to vascular, um, either vascular surgery and or vascular lab to get an ABI if we can't do it in the facility itself. So that can go on ID. Um, that can go on, but at a minimum, the wound nurse, every other nurse that's taking care of the patient, not just those that change dressings, but all the other aspects that need to be addressed as well. And then to make sure that the PCP knows what's going on and what your thoughts are about what we can do to help improve these wounds. So that you got multiple people reinforcing the plan to minimize damage to skin and or treat wounds that already exist.
Awesome. Another question, is there any standard wound care to put in place for the floor nurse before your wound team or before their wound team can assess the patient?
I think the short answer is no. Um, to me, this gets into the area of personal preference. And so for me, the answer is honey and foam. Those of you that work with me are probably smiling now because um, I don't think there is a standard. Um, so it depends. Um, but I think it's worthy of a phone call and or a text to say, I've got this wound. Here's what it looks like to me. What should I do till you get here? Uh, I think that's really the best answer is text or call and say, here's what's going on. What should I do till you can come look at it? And then we can decide together what to do.
Awesome. And then do you mind if I expand on that, Dr. Red?
Sure.
So I would also say if if for whatever reason you can't get a hold of the wound care provider and maybe it's the weekend and they're not responding back to you, a good indicator is if the wound needs moisture, put something on that will provide that moisture. So your gels, like Dr. Red said, honey foam, honey silver gels of some kind in a bandage. But if there's way too much moisture, then to get something that allows that moisture to get away from the wound bed. So an alginate, for example. And then if you have something that is very deep, then just make sure you're packing the dead space. I think that's probably the most important thing we can do if you have a wound that is deep. So making sure we're packing with gauze or plain packing strips. Into with some sort of Anicept, Silver, Dakins, any of those products can help. So those are kind of my three go-to, fill the dead space. If there's a lot of drainage, get rid of it. Or if there's a need for moisture, add moisture to it.
Good. Yeah.
Any other questions? Oh, we got another one. When is a surgical closure appropriate for these patients? And what can we do to optimize their wound to increase their chances of being a surgical candidate?
So I find that pretty rare in the people that I see, because to get a good closure, you need to do it without any tension. And since most of these wounds are round, that's really challenging. So I'd say if you can squeeze or bring the edges together with minimal to no tension, then that's probably a good time to consider surgical closure. Um, uh, I see that probably most common in wounds that start out as a surgical wound, particularly infected midline abdominal wounds. But most surgeons are going to be reluctant to try to close that because of infection already present in the wound. But what can we do? Add anything that's going to promote wound healing to make it smaller may it would help get it to the stage where it could possibly be closed.
Awesome. Any other last questions or thoughts before we close the webinar? Doesn't look like it, but we'll stay on for a couple of minutes just in case one pops up. But thank you so much for attending today, and we hope to see you at the next one. Hope you guys have a great day.